All right, let's talk a little bit about the different kinds of aneurysms before we move to ruptures. So there's two big kinds of aneurysms you should be familiar with. There's the saccular aneurysm, which is also sometimes called the berry aneurysm. Okay, so it's kind of synonymous either way. And these tend to arise at branch points where there's higher pressures. Classically, the big artery to remember is going to be the anterior communicating artery. Okay, this is one of the most common sites that this is affected. Now, technically, you can get saccular aneurysms at a lot of different places in the anterior circulation. You can get them at, like we said, the anterior communicating artery, the middle cerebral arteries, the posterior communicating artery, right? So, but this is one of the classic locations. The big risk factors, again, just going back to the last video, I said you can't really go wrong when you're talking about hemorrhage and ischemic stroke. Hypertension is always going to be a major risk factor. Smoking, right, tobacco use is also going to be major risk factors that we're going to associate with these kinds of aneurysms. And if they rupture, they can be life-threatening. So the classic rupture, if you have a saccular or berry aneurysm, the one that gets asked about is going to be the subarachnoid hemorrhage. Okay, now there are some unique features about this that I'll talk about in a moment. So I'm just going to come back to this in a second. The other type of aneurysm that we're going to talk about is the Charcot-Bouchard aneurysm. Now, remember, I said the saccular is primarily going to be associated with the anterior communicating artery, posterior communicating artery, maybe the middle cerebral artery. These Charcot-Bouchard aneurysms are pretty much exclusively, when in board questions, asked about with respect to the lenticulostriate vessels. Remember, these are the small penetrating vessels that are going to cause, in the last video, the lacunar strokes. And so again, in this situation, if we have these aneurysms here and they burst, right, or they rupture, you're going to get lacunar hemorrhages. So you'll have your classic lacunar stroke, lacunar hemorrhage findings. If you're affecting the basal ganglia, you'll get the classic basal ganglia findings. If you're affecting the internal capsule, it's really all of what we talked about in the last video. But again, the key point that I want you to take away from this video is that these Charcot-Bouchard aneurysms are more associated with the lacunar hemorrhage, whereas the saccular are more associated with subarachnoid hemorrhage. And one way that you can kind of differentiate these two is that the subarachnoid hemorrhages will tend to have no focal neurologic deficits present. Usually they'll have meningeal signs, actually, because of the irritation at the arachnoid or the pia. Whereas with the Charcot-Bouchard aneurysms, we do expect focal neurologic deficits quite often, especially if we're affecting the internal capsule. We can have a pure motor stroke, a pure sensory stroke. So these are things to consider. Now, I keep talking about high blood pressure, hypertension being a major risk factor. But, how do you differentiate hypertensive encephalopathy from hypertensive hemorrhage? Okay, so if I just had, if I have really high blood pressure, let's just make up a number, 190 over 110, okay? And if this hypertension is causing me to have a really bad headache and some encephalopathy, the thing is, if this was just an encephalopathy, right? If it was just an encephalopathy, I would not have focal neurologic deficits. Okay. However, if I had really high blood pressure and it led to, a rupture of Charcot-Bouchard aneurysms from the high blood pressure, then I would probably have some focal neurologic deficits. Okay. So if it's just encephalopathy, I typically would not expect to have focal neurologic deficits. You might have confusion or altered mental status, but that's how you would differentiate a hypertensive encephalopathy from a hypertensive intracranial hemorrhage. When we see hemorrhage in this area, this will be very classic. Usually in the area of either the internal capsule of the thalamus, the basal ganglia, this is usually where we'll see these lacunar infarcts or hemorrhages. Okay, so other high yield locations for aneurysms in general. The two big ones I want you to remember are the posterior communicating artery aneurysm and the anterior communicating artery aneurysm. And again, remember the locations of where these arteries are at on the circle of Willis. Now remember, the posterior communicating artery aneurysm we've talked about a little bit classically affects the oculomotor nerve. The posterior communicating artery actually courses along with the oculomotor nerve, making it particularly susceptible. So if there's an aneurysm there, it'll pinch down on the oculomotor nerve. And remember, the parasympathetic fibers are running superficially, so those tend to get affected first. Okay, so if you just have an aneurysm on one side, right, you'll tend to get a dilated pupil on that side. You might get a down and out pupil potentially. You might have some ptosis, and you'll get the dilated pupil first because, again, parasympathetic fibers are running superficially, and over more time, eventually you'll pinch down on the somatic fibers, right, and you'll get more of the down and out pupil when you affect most of the extraocular muscles. But again, they can also say this, instead of saying dilated pupil or mydriasis, they can say that there's anisocoria. Okay, so anisocoria just means that the pupils are unequal in size. Okay, so that's another way that they can say this. Okay, anisocoria would be another example, or maybe the pupil has a loss of accommodation. Okay, so that can also happen if you affect the parasympathetic fibers on cranial nerve 3. So just remember, there's all different ways they can ask this. Now, for anterior communicating artery aneurysms, this is going to affect more of the optic chiasm. So remember, when you affect the optic chiasm, you get a bitemporal hemianopsia, right? So you're going to knock out both sides of the temporal visual field, which affects the nasal retinal fibers.